Assalamu alaikum warahmatullahi wabarakatuh. I'm really sorry. I think my recording was on, but my mic was mute, and I will have to speak out from the start again. So actually, the laryngospasm is a complication which can occur in light plane of anesthesia, and if a little bit of spasm occur a number of times, but if we manage in time, not not big problem occur, but if we don't treat it in time, it can become a serious problem. So it can cause even negative pressure pulmonary edema. It can cause even hypoxia. Okay, and so the best option is that you should avoid extubation or in light plane of anesthesia. Sometimes we are having inhalational induction, especially in pediatric patient. Um, uh, and sometimes if IV line is not taken, never try to manipulate the airway because it can cause laryngospasm. If you fail to intubate, for example, it can create problem. Even sometimes if we try to put LMA, because supraglottic airway device cannot prevent laryngospasm, and laryngospasm can occur with supraglottic airway device. So it's a very dangerous thing because in that case you will not have IV line, for example, and you try to manipulate. If anything occur, you cannot do anything. So that's a big problem. Even the you will not be able to deliver the anesthetic mixture which you are trying to give. So this is something very important. So how to manage it? We just have try to close the APL valve and try to create a CPAP. Okay, then there is a maneuver which is called as Larson's maneuver. I'm afraid the spellings are correct. Larson's maneuver. Just behind the angle of jaw, we give a painful stimulus, and a number of time it relieves the spasm. The same time, if secretions, doing suctioning is a two-way sword. If you do suctioning, if there is secretion, yes, it can help. But actually, suctioning can worsen laryngospasm. So you have to be careful in evaluating whether you should do suctioning immediately, or you should try to increase the depth of anesthesia by giving some, for example, like propofol or lidocaine. Okay, so you just have to decide, or you have to evaluate the situation. So CPAP, Larson's maneuver, suctioning, propofol, lidocaine. If it does not work, the next step will be low dose of suxamethonium. Okay. Uh, Even if it does not work, then you might need to give full dose of suxamethonium or muscle relaxant to intubate the patient. You will have to intubate the patient, or um, like uh, usually in majority cases, in these 3 4 steps, patient is relieved. But if does not occur, there is generation of negative pressure pulmonary edema, uh, because the glottis is closed and airway muscles, they are contracting very heavily, and there is obstruction here. Okay, it's so all the negative pressure which is generated negative intrathoracic pressure, it will cause leakiness of capillaries, and like pulmonary edema will occur. So if pulmonary edema occur, you will have crackles, and then you will need to give some like furosemide diuretic. You need to ventilate the patient uh, with PEEP. Okay, and there is no role of steroids in this case. You just need to ventilate with PEEP, and patient will be uh, uh, like patient will come out of this vicious cycle. Another important thing is that you then in that scenario you will have to consult the family, and then the patient need to be shifted to actually ICU or HDU. If you are able to extubate, then you will send the patient to HDU. Otherwise, you will have to send the patient to ICU. By the way, What is difference between ICU and HDU? Anyone knows what's difference between ICU and HDU? In ICU, either mechanical ventilation or two organ support. Either mechanical ventilation or two organ support. Like for example, if the patient is on high flow oxygen therapy as well as patient is having inotropes or vasopressors. So it means two organ support. Similarly, if patient has inotropes and the patient is on dialysis, so this is also two organ support. So this is ICU and HDU if only one organ support is needed other than mechanical ventilation. So this is the sequence of event for laryngospasm. Uh, Another very important, uh, just a second, please. We have opened the source. Why to reopen it? Okay. So another very important topic I have discussed a number of time before. I will be doing it again. What do you mean by never events in anesthesia? Never events in anesthesia. Actually, never events is are the thing which you can avoid, and like there are so many things which comes into it. Like for example, you give you have wrong patient, okay, or wrong site of either surgery or you give a block to a wrong site, okay. Then for example you give wrong medication or it may be wrong medication, wrong dose, wrong concentration, wrong route, okay. Like you give in inadvertently you give intra-arterial, or some medication is supposed to given to be given intramuscular and you give IV. It was to be given slowly, infusion you give it fast, okay. So uh, this is one category. Then like for example there is drug extravasation. So this is also a never event. So now if for example drug extravasation has occurred, so how will you handle this situation? Nobody is actually interacting, so anyone wants to speak out, please?
Sir, I have a question.
Yes.
Sir, for laryngospasm, one thing is to prevent laryngospasm, one thing is if it happens, then to do measure to correct it.
Okay.
Is there some role of spray, lidocaine spray for its prevention or its treatment?
Uh,
Because superior laryngeal now involved in it, so if to numb it or to numb the vocal cords.
Theoretically, it can cause it can prevent, I think, but actually it can trigger laryngospasm as well. If any foreign body is coming, it can trigger because actually it's light plane of anesthesia, which is creating the problem. Okay, so uh, it's the main thing is that. Okay, yes, actually IV lidocaine will have membrane stabilizing effect, so it can prevent rather than spray. Because do you know laryngospasm actually is a protective reflex? It's causing a protection. Like even if you like when we someone pinch the one like we do like this, actually this is sort of laryngospasm. Have you seen babies? If you touch them or if you try to do something which they don't like, they breath hold. Okay, so at that time actually they close the glottis very tightly. So it's like that. Okay. So anyways, so Saifullah, if we have drug extravasation, what should you do?
Drug extravasation, sir. First, I should check that which drug has been used,
Okay,
uh, and how much the drug has been given,
okay.
and at what site it has been given, uh, and
Actually,
then,
it's not
uh,
necessarily only drug. It is, for example, IV fluid. You put a cannula and it was half in,
sir,
half out, and fluid went into, and the limb is swelling. So it's also extravasation. And the first thing, as mentioned in
stop
the
infusion.
the message as well, that you will stop immediately giving
Stop, yes,
any
sir, stop.
further. Okay. And then if it is like fluid, the cannula was not properly in, you will change the IV fluid to other cannula. You will take another one and you will elevate the limb. You will have crepe bandage, and with passage of time, it will be absorbed. But important thing is that, like for example, if it is, you have given muscle relaxant, so now you have to be very careful because it can cause like respiratory insufficiency, because gradually it will be absorbed. So you can expect and you should observe the patient. If the patient was, for example, day case, you will try to observe him for extended time. You might need to admit the patient, not necessarily, but it depends on how much dose was given. A number, it's a common thing. Even sometime it's draped and you don't know. I myself faced a pediatric patient. IV cannula was done very nicely, but when they were doing the fixation, not properly fixed, it came out a little bit. Whole of 500 ml fluid was going. Actually, it was going, but it was in subcutaneous tissue. Half was in, half was out. So that's why it's very critical to even fix the any IV cannula. Okay. So this is,
Sir,
and for wrong IV medications or wrong side, the best option will be drug labeling. Okay, the proper
sir,
labeling with concentration, and ideally the person who is preparing the medication, the one who has to use, should prepare by himself, and there should be double check. Like once he filled it, and then he should double check one what he filled. Or if two people are doing, even they can have a check, that one person is filling it and the other person is can have a double check. So that's why proper drug labeling with concentration and route. Another mistake in similar way can occur, that for example it was an arterial line, and by mistake you did not see and you give like IV, considering it as an IV. So these are the things which you should, like for example, if you have given intra-arterial, so because all the material is written about the thiopentone, but actually any other medication can be given. Any medication can be given intraarterial. So it depends on the character of the medication, and you can have a sort of embolic effect. It can be very painful. So usually, what should because they always cause about thiopentone. So for thiopentone, what you need to do, Safullah?
sir, again, we have to stop the infusion, leave the cannula in place.
Okay, you
Uh,
can have some normal saline, flush or normal saline.
Sir, in literature, there is written that we can inject some lidocaine if it is very much painful.
Lidocaine, and if there is chances
Uh,
of thrombosis, papaverine.
then heparin can be given so
Heparin
that
or papaverine,
or piperine, which is vasodilation. And then
and
if still persist, then stellate ganglion block is
stellate
used, and the
ganglion.
patient consult before that for that. And with consent, stellate ganglion again should be
Yes, and
given.
you have to monitor the limb for thrombosis.
Mm.
Okay,
For
Later on, if
thrombosis,
the limb color change, okay, especially in
sir.
upper limb, if you have injected in main radial artery or brachial artery, it can cause thrombosis and even ischemia. So you have to monitor, observe the patient for it. Okay. Then there is something which is called as WHO, Surgical Safety Checklist. You know about it?
Uh, Sir, there are three things before giving anesthesia, before giving incision, and before the surgeon, before the patient left the OT. Uh, for before giving anesthesia or sign in, I think that's called sign in. Actually, the confusion arises when they have written sign in and sign out in this. For this, we have to first confirm that the name, age, sex of the patient means identity of the patient, the actual site of the patient. The We have to check our drugs and anesthesia machines and oxygen delivery, uh, and other things we need to ensure. I think. I'm forgetting whether the blood loss and the patient concerns and are in this, or that is included in
Any
the
blood loss, any you are expecting any
in
like any
the
critical step, okay? They check
critical.
whether the anesthetic and surgical equipment is there, okay? So whatever is needed, they review everything. Any like some things are done at the start, at sign in, and then time out before they give the NCN. At that time, they ask
Sir,
the surgeon even there everything required is there, like any imaging is needed, any equipment is needing, antibiotic prophylaxis, where is this is actually to prevent such mistakes, okay?
proven.
Because
Yes,
even I think no anesthetist can say that he does not have any error in his career. If he is saying, he's lying. It's not possible that such mistake does not occur. It occurs, and the best way will be that you learn whatever you do a mistake, you uh, document it, you inform everyone so that others. It's also with the LASA, look alike,
look
uh,
like and
sound alike medications. Okay, so
sound.
so same thing, like we, because we are discussing as a whole the existence of this never event. So WHO surgical safety checklist is one of the prevention for it. Okay, and actually, if
Yes,
one day when they do sign out is that they will say what was the procedure, well, now where the patient is supposed to go, any specimen and any something like from there onwards, any message for PACU, post anesthesia care
sir.
unit. So these are the things which they do with this reference. Okay,
Yes, sir.
so okay, doing a procedure without a consent. Okay, like or very funny incidents which when I was a very junior resident. One day, one of my senior just mocked me. He just made me sweat like anything because there was a hysterectomy. Sorry, there was a tubal ligation who was done without the consent of the husband, and he was a very aggressive person. And my senior colleague, he said that you gave spinal to that patient, and now please don't go out because the husband is looking. So this was a funny event because was very junior and I became so much afraid that if I go out, he will hit me. So, anyways, so any procedure like you give blood without consent, because there are internationally there is a Jehovah's Witness. So if you give blood to a Jehovah's Witness, which they refuse, so that is also a never event. Then any procedure without consent, you did not take consent for the regional anesthesia and you give intraoperatively, you give without taking the consent. So these are are also you can say part of what we are discussing. Okay, so we will just try to have, we have discussed a number of things. Wrong site surgery, okay, wrong site anesthetic blocks, wrong implants, retained foreign
Wrong.
object. Yes, very important that from anesthesia side, which foreign object you can retain, you can
Sir,
forget to
throat
very good.
pain can be retained.
Throat pack, okay. So throat pack, there are case reports in which the throat pack was even removed in the ward. It's something, and unfortunately a very bad incidents that sometime tourniquet, because if someone, because sometime pneumatic tourniquets are not being used in low resource setup, they are using uh, like any plastic and any material tubes, even they want, you know. So there was incident that tourniquet was removed, not removed. Even you take IV line, you put a tourniquet, you forgot to remove it. It's also
Yes.
something very dangerous. Okay, and so like
Sir,
similarly, sorry.
sorry to cut you. Cautery burn, if it has
Yes,
been not been prevented, it's
MRI, like
also.
yes, actually, if you put a pulse oximeter, or you there are some pulse oximeter disposable. Okay, so they have a tape by which they are attached, and they forgot to remove it, and you put the patient in MRI. It can cause burn. Okay. Similarly, there are so many incidents like you did not pick a patient who has latex allergy, and you use something latex, because latex allergy can cause even anaphylaxis, but it can cause rashes as well. So you did you even inadvertently you do it. You know that the patient has latex allergy, and or you don't know it, and use latex, and now this is also sort of never event. Okay,
Sir,
so
there was one event occurred. The younger lower side, which is ball
was
like,
broken.
it was loose. And when I was doing suctioning, and it went into stomach,
Yes,
then
actually,
technician
this
then
occurs.
technician.
I will explain
Yes,
because majority part of word now that's disposable. So actually, there is a metallic suction. There is at the end there is a removable part. I have used it so
yes.
I can understand what is it. So it can open up and it can fall down. So this is yes. Okay.
So it was
So
recognized by technician that where is it is. I have given you the complete set. Then we ordered an X-ray. Then it was recognized, and it was done endoscopy. Then it was removed.
yes. Okay.
Little
So
things can become very big things.
yes. So okay. Wrong blood administration. Okay. And overdosage we have actually discussed. You okay. So this is some like you can make enhance the list uh, of the never events: misplaced nasogastric maladministration of insulin, long drug administration. So anyway, this is a question which they can ask you, and just have to understand the gravity of this question. And there is something which is clinical negligence. This is, I think, something else. You okay? So okay, awareness is also sort of never event. Okay, so let's discuss awareness as well. So just tell me one thing. What is awareness?
Sir, the
वही
intraoperative event which has been recalled, whether partially or fully, could be called awareness, isn't it?
Okay. So who else was speaking? Sadaf, you were speaking. Anyways,
Yeah, or
so
we could say
yes,
that patient conscious recall of events
yes.
during anesthesia, which could be due to inadequate depth of anesthesia.
Inadequate depth of anesthesia, you gave muscle relaxant, and the muscle relaxant was more than the depth of anesthesia you were giving. So the patient will not be able to breathe, and patient will be listening to everything. So that is one of the factor for awareness is giving muscle relaxant is one of the cause. Okay, because why? Because if, for example, you have not given muscle relaxant and depth of anesthesia become decreased, patient starts moving, so you will come to know that the patient is awake. But if you have given muscle relaxant, the patient is not able to move and patient is listening. So that's the concept of giving muscle relaxant. So similarly, MAC awake is like less than zero point 0.5, okay? And you need to maintain more than zero point 0.7. You see, adequate administrative rate of and point more than zero point 0.7 for volatile should be maintained, and hemodynamic consequences of anesthesia should be dealt with separately. Okay, so if like if needed uh, uh, if the blood pressure is low, you can give some vasopressor, inotrope, or you can replace it with some other medication like ketamine. If you have given ketamine, here they have written benzodiazepine do not prevent awareness or recall. This is something else. But actually, if you are giving midazolam as a bridge, so it will decrease the requirement of inhalational agent. Because why it's like that? Because midazolam itself cannot prevent, because midazolam is short acting. So it will not bypass. So it will just transiently decrease the requirement. So it's like that. Okay. So one is explicit memory and one is implicit memory. So explicit is when the patient is totally recalling, and implicit is like half memory. Am I right? So half of it he's remembering and half is not remembering. Like part of it he's remembering. So uh, they will evaluate the patient, because this is a question they can ask you in even in talks, that you will have a patient who have developed uh, awareness. Okay. And now you have to counsel that patient. So it's actually a tricky scenario, that how you need to other factors other than anesthetic is like, for example, vaporizer was not working. Okay. And if you are giving PIVA, it can cause the line was not good. Like we discussed, the line, the drugs were extravasated, or line was blocked inadequately, and you did not replace in time. So there transiently there may be development of uh, awareness. So one option will be to monitor BIS, okay, and other option is with the agent analyzer. So these are two different things actually. BIS is like a bispectral index. Okay. Some words about Bryce questionnaire. This is, Fahad, I tell you something. These are very, actually, I practically, like I tell you something, you will never recall these things in the exam. Okay. I don't think so. It's something very important. But anyways, since you have told it, what was the last thing you remembered happening before you went to sleep? What is the first thing you remember happening on waking? Did you dream or have any experiences while you were asleep? What was the worst thing about your operation? What was the next worst? I don't know how to explain. Uh, yes. So anyway, so one is bis entropy, and if they are doing proper neurophysiological monitoring, they can have that the full EEG, and then they can also, because when they are doing neurophysiology, they are monitoring it. Okay. There will be certain scenarios in which there will be chances. One of them will, for example, bleeding. So if a patient is bleeding, then this patient can have awareness, because if the depth of anesthesia you decrease it, so at that time there is like you can exception, and even sometime when we are counseling, you this is a possible explanation. You say that the patient, you were bleeding, and the anesthesia medication were further causing fall in blood pressure. So at that time, to save your life, we don't have any other option other than to decrease the anesthesia. So that's why you develop this awareness. Okay. So, okay. They ask sometime about this NAP. NAP is National Audit Project, especially in international exams like British exam. They can ask you, and then you you need to know the incidence. Okay. So estimated incident reports of awareness under general anesthesia, 1 in 19,000 anesthetic. Okay. And they will ask you the risk factors. They can ask you about neuromuscular blockers, thiopentone, PIVA techniques, patient factor, female gender, age, uh, obesity. previous awareness under general anesthesia. Okay. Mm, So usually awareness occur at the time of induction and recovery. It can occur in at any time, but usually at that time patient can recall a number of things. So okay, just a second. In ICU, drug error, obstetric anesthesia, cardiothoracic anesthesia, human factor. You can have recommendations, okay? So recommendation, they will tell you that what you should be doing. And nerve stimulators as essential in monitoring guidelines whenever neuromuscular blocking drugs are used. Then they say that engage with the industry to seek solutions to problem of similar drug packing and presentation if you have to drug errors. Then all anesthetists should be trained in the maintenance of anesthesia with intravenous infusions, TIVA. Okay. The relevant anesthesia should establish a set of standards and recommendation for best practice in using TIVA. There is a TCI is one form of TIVA in which there are set like uh, models, set models which uh, deliver a specific, we maintain a specific drug level in the blood. There are TCI model target control infusion models for fentanyl, remifentanil, propofol. Okay. So what else? Should be familiar with principle and use of EEG, depth of anesthesia. Okay. Then whole nothing much important. But usually, actually, they don't ask you that let's discuss about NAP. It's not like that. You should be knowing the basic things, basic components, which can increase the safety. Okay. So because this is a topic which is frequently asked topic in the exam. You're doing this. Okay. Any question or anything you want to discuss? We have done a number of, yes, actually, airway fire. Okay. So what will you do in airway fire?
Sir, first of all, we have to remove the ATT.
Okay.
Then we will shut off the main oxygen supply.
Okay. You are
And then
forgetting
get
this call for HUD.
inform the surgeon. And, sir, first of all, we have to inform the surgeon. Then remove the burning airway.
Okay.
And any source that is like par ignition, that is वो off करेंगे like oxygen.
Okay.
And then irrigation with the normal saline.
Okay.
And then change switch on the patient to the from to manual ventilation.
Okay.
And try to
You might need to re-intubate. Okay.
re-intubate
And
and start with the
then
manual intubation.
we will do the bronchoscopy to assess the injury. Okay.
Yes.
And so stop all airway gas flow by disconnecting the breathing circuit from the anesthesia machine. Okay. And then you remove the tube, you irrigate, and then you re-intubate. Okay. And actually, usually they are doing it laser, so there are laser resistant tube, there are saline filled syringes you should be available. Okay. And another thing is that they have this methylene blue tinted saline. If the cuff is ruptured, then you will come to know. And wet gauzes. Okay.
Yes, sir. Irrigation of the surgical field.
Yes. Mm. Okay, so one topic we will discuss is about bleeding. Usually, what is the approach? Like suddenly unanticipated bleeding occurred. This is one scenario, or in a preparation also, that how will you prepare for a patient who is at risk of bleeding, like for example bleeding, because bleeding can be like in the form of this maternal hemorrhage or trauma. So if you have a bleeding patient, how will you like approach? One thing will be to assess the level of hemorrhage. So there is hemorrhage classes, so you should be knowing about it. This is also part of trauma. Class 1, class 2, class 3, class 4. You should be very clear about the sign and symptoms in each class. So this is one thing. You will take large bore IV cannulas. What will you do then? Should you
Sir,
take RT?
first,
Yeah.
Sir,
Yes.
arrange for meanwhile arranging the blood, we have to infuse the colloids.
sir, first we have to see if, whether the airway is secured or not. If the case is under regional anesthesia, we should think that how is the condition of the patient? How is his or her airway? How is
Yes.
his or her breathing? Is then we have to see whether the circulation means the blood pressure, the heart rate, the saturation, the capno if the patient are already intubated. We have to
Mass
assess the grade of class 1,
airway
class 2,
breathing
class 3.
circulation, activate massive transfusion protocol. What is this massive transfusion protocol?
And massive transfusion protocol, sir, there is usually we give 1:1:1, the
No, this is
RBC,
not
FFP.
no, no, no. No, no, no. This is not massive transfusion protocol. Massive transfusion protocol is a like you can say, uncross match O negative or O positive blood group. Okay, with the like 6 units of PRBC, 6 units of FFP, 6 units of crab precipitate, platelets. So this is called massive
Uh,
transfusion.
yes,
You
sir.
then need to.
Like rapid process of infusion of APPs and
Yeah, no,
RBCs and
this is
platelets.
a specific thing which is called as massive transfusion protocol. Okay. You should be very clear, because any bleeding patient, you don't need to have the cross match. You have to bring uncross match O negative or O positive blood group. Okay.
Okay, sir. Thank you.
And there is a specific number in which you will announce like a code, uh, activate massive transfusion protocol. So immediately this crash pack will come. So it's also called as crash pack. So the blood and blood products will come. This is for emergency management. Okay. So in different scenarios, different categories, also you will now also monitor. So you can have arterial blood pressure, so that because if there is hypotension, you need to monitor the blood pressure beat to beat. This is one thing, and then you will do ABGs, serial point of care testing, also ROTAM or TAG for further management. Okay, because now this patient can have DIC if you are giving not only the complications related to MTP, massive transfusion, massive bleed, like massive blood transfusion. Okay, so all the
Sir,
complication of yes.
sir, sorry, and again to interrupt you. Sir, the tick doesn't tell us about the RCC transfusion, red cells concentrate. So it tell us about the FFP or platelets as far as its structure are
Yes.
like
So
RA,
ABGs,
alpha,
ABGs,
yeah.
ABGs will tell you what you should trust, hematocrit or hemoglobin.
Hematocrit.
For example, if
Hematocrit.
hematocrit is 20 and hemoglobin is 10. So what is the corrected hemoglobin?
Uh,
6.66. So 20 divided by 3. Okay. This is
uh,
the
20.
actual hemoglobin.
Okay, sorry.
And this is called as hemoconcentration or hemodilution.
Sir, hemoglobin is hemodiluted. That's why we shouldn't
No, 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 no,
take
no,
it.
no, no, hemoconcentrate. That's why it's showing
Hemoconcentration.
yes, when you will give fluid, the actual hemoglobin will come. And that's majority of time happens. Okay. We start the case with hemoglobin showing 13, and after 1 liter or 2 liters of fluid you have crystalloids you have given, the hemoglobin fall down to even 9 or 8 because the patient is dehydrated and it's short of because actually it depends on pre-existing condition. Okay. If there is like fresh blood loss, dynamics will be different. If the patient is already anemic or already having some hematological problem, on top of that bleeding occurs, things will be a little different. So that's how. So other maneuvers which be tourniquet will be one thing.
Sir.
Limb elevation or surgical site elevation to avoid engorgement. Okay. And if
Sir.
you are dealing with the uh, maternal. So uterotonics like oxytocin, ergot, methergin, this one carbopost and misoprostol. Okay, and then B-lint suture, surgical manipulations, internal iliac artery ligation, Beckery balloon. These are the things which are being used for maternal bleeding. Okay, and the last but not the least will be some other things which will be helping. Will be one of them will be tranexamic acid, which will be helping to control. What is the mechanism of action of tranexamic acid? It's
Sir, it is antifibrinolytic.
fibrinolytic. So what is the mechanism of action?
Uh, Sir, the fibrin doesn't split. Uh,
No. It is preventing the conversion of plasminogen to plasmin. Okay.
Preventing
Which is
plasmogen to plasmin.
yes. So this is the one which is plasmin is breaking fibrin. So you are blocking the factory which is breaking the fibrin. So that's why the microthrombi which are cleared by the plasmin system, it will be stopped. Okay. So that's the concept of tranexamic acid. And last is factor 7,
7.
Nova 7. So it is because on the basis of cell-based theory, it is for initiation, amplification, and propagation. So this is like you are putting a fuel to fire. Okay. So then rest of the things are rapid infuser, level 1 infuser, which are able to even transfuse up to 500 ml to 1 liter per minute. Okay. According to the level of infuser, you take large bore IV cannulas. Even in liver transplant, they are taking IV sheaths. Okay. So this is for rapid transfusion. Then another thing come into account is cell salvage. Cell salvage. Okay. So cell salvage will be in that one. You are able to build up you are saving the hemoglobin. So it will only give hematocrit. It will not give any products. And there is a system by which they can concentrate up to 70 to 80% hematocrit, things like that. They will take the blood, do the suction, wash it, and then retransfuse. Okay. So this is the concept of cell salvage. As I was mentioning, you can elevate the limb. You can I know that this is not a seen that number of time when there is bleeding, hypotension, controlled hypotension or controlled hypotensive anesthesia can be used to decrease the blood pressure. So to decrease the bleeding. Okay. So this is something. These will be the options for you. Let's see. Of course, if the blood pressure is going down, so that was I was telling you. Okay. So you see, there is a specific numbers for MTP. So 4 units PRBC is around less than 4 hours, activate MPT, and then it's 6 units PRBC, 6 units platelet, 6 unit FFPs they will send. Okay. And later on, you have to look for DIC, and will have to look for all the complications, metabolic complication, hyperkalemia, hypothermia, okay, of stored blood. Or and another problem will be related to blood grouping. Even blood grouping, there will be a problem. So if I'm not wrong, after 3 units, if you have transfused, you have to transfuse the same unit up things like that. I am very bad at this topic. Bilal, if you can help me out. Bilal is here with reference to giving. Are you available, Bilal?
What is question? Say it again.
For example, if you have given O positive or O negative blood group, okay, and now the cross
Hmm,
matching
hmm.
cross match. So after how many units you need to give the same blood, or you need to do the again blood grouping? Am I right?
Oh, no idea. It's an interesting question, but I don't know that.
Okay, I
But
cannot
usually there
recall it.
is something like in pregnant patient there is a very
No, that is
interesting
something else,
question they
Bilal.
used to ask, but
That
that,
that is
that's a
that
different
is
one.
related to O positive or O negative, because
Yeah.
they
That's the
pregnant patient.
RF factor. Yeah.
Yes, so that
Mhm.
is related to RH factor. And pregnant patient or
Yeah.
female of fertile age should be given O negative, and the rest of the patient can receive O positive.
Yeah. Yes. It's
So
like that.
I hope you understand my question. So if you have the answer, please
Yeah,
let me
I
know.
understand, but I don't have it. Yeah, but I can look into the literature and tell you, but right now I don't know that.
Yes. So because if you have given 3 units of some, you need to do the blood grouping again. Okay. And then hypocalcemia, hypomagnesemia, hyperkalemia. And when you are giving more units of blood, you always have to check the blood groups properly. There should be two people who will be checking the blood, two different steps. The porter who is bringing the blood, he will check outside and then again in the room, because there are incidents they took the blood to the wrong room. If you are working in a busy center having a lot of rooms, so there are incidents, even hospitals like as big as King Faisal, there was an incidence of blood coming to the wrong room. Bilal, there was incidents like that. Luckily, because in OR, another question. This is also that how will you check the blood in the anesthetized patient? So you not only have to check the band, you have to check the patient file, because sometimes they are coming with a card, okay, and you are just checking the card with the blood. Of course, it will be the same, but you need to identify the patient as well. So sometime maybe the card and the blood is the same, but it not does not belong to the patient in which the blood has come. So that's why whenever you are transfusing blood, you make sure you have the patient file or patient ID band, okay. Or if it is electronic system, they are in our hospital there is a system of bridge, so they actually scan the barcode, and then automatic all the information comes in the system, and then they transfuse the blood. So that is how they proceed with it. And also then you need to have the transfusion triggers, because how much hemoglobin you need to build up in a bleeding patient. Sometime if you are overcorrecting, a number of scenarios you don't correct everything. Like in, for example, liver transplant, even if the blood bleeding is occurring, you don't correct everything. You don't give FFPs and platelets in 1:1:1, because it will cause thrombosis. So, with the of course, they do thromboelastography or ROTEM, and they do also INR. They check even ACT. There are so many ways to monitor it, and then they keep the patient slightly on the coagulopathic side, because they just need to have the surgical hemostasis. They don't want to correct everything so that thrombosis will occur. So this is a point you should be knowing. And then vitamin K or protamine, if heparin is being given, tranexamic acid, factor 7A, which I was. Another question, it's a very simple question, but they can ask you how to calculate the estimated blood loss. You will have to calculate the blood volume for that patient, and then according to the situation, you will say how much hemoglobin you can allow. So that will be the allowable blood loss. And before allowable blood loss, you have to replace the fluid with 1:1 for colloid and 1:3 for crystalloid. So that's how. And after that, if it is more than allowable blood loss, you have to replace it with the RBCs. Okay. So we will stop here, and we will continue, inshallah, tomorrow, most probably. So thank you, all of you, for joining.
Thank you, sir.
Abdurrahman, you came very late.
Yes, sir.
Okay, so we will continue from here tomorrow, inshallah. Bye bye.